Hello everyone, this is Dr. Neelam here. Today I have come with one of the most common presentations to emergency department, that is heart failure. We'll be discussing mainly regarding the aspects from emergency department itself. I'll be speaking about causes, precipitating factors, pathophysiology, stages, clinical manifestations, differential diagnosis, management from ED. So coming to what is heart failure basically? It's a complex clinical syndrome with symptoms and signs that results from any structural or functional impairment of ventricular filling or ejection of blood, which in turn leads to pulmonary edema and systemic congestion. So it is one among the common presentations in emergency department with a high morbidity and a mortality rate. Approximately 50% of the patient die within 5 years of the diagnosis. The overall sensitivity of heart failure diagnosis in the ED is 65%, and acute heart failure is the leading cause of hospitalization in patient more than 55 years. 65 years. The hospital mortality ranges from 4 to 10%, with post-discharge 1 year mortality ranges from 25 to 30%, with up to more than 45% of readmission. Coming to the causes, the most common cause being the ischemic heart disease, followed by the other causes. The other causes may be like hypertension, valvular heart disease, chemotherapy induced, causes like endocrine, rheumatologic or autoimmune causes. Could be due to infiltrative cardiac diseases like amyloid, sarcoidosis, myocarditis due to any reason, peripartum cardiomyopathy and stress cardiomyopathy. Next, coming to the precipitating factors, uh, mainly could be due to non-adherence, like excessive salt or fluid intake and medication non-adherence. In case of renal failure due to missed dialysis, and other precipitating factors could be due to substance abuse, poorly controlled hypertension, and iatrogenic causes wherein newly added antiarrhythmic agents or recent addition of any negative inotropic drugs or inappropriate therapy reductions. Next, coming to pathophysiology. Pathophysiology, basically any threat to the cardiac output from myocardial injury or stress, leads to further triggering of the renin, angiotensin, aldosterone system and sympathetic nervous system, which in turn leads to increase in the level of noradrenaline, vasopressin, endothelin and tumor necrosis factor alpha. These hormones basically are generally not measured, but their levels directly correlate with the mortality. So this leads to further water and sodium retention and increase in the systemic vascular resistance, which maintains the BP and perfusion, but at the cost that there will be further increase in the myocardial workload, wall tension and oxygen demand. Although some patient initially may be asymptomatic, a secondary pathologic process, uh, that is cardiac remodeling, begins to occur, eventually triggering more dysfunction. There is further counter-regulatory response by releasing natriuretic peptides, which further leads to vasodilatation, natriuresis, and decreased level of endothelin, and it also leads to inhibition of trans. So this is how basically cardiac failure pathophysiology is. So next, coming to stages, basically they are divided into 4 stages according to European guidelines. Stage A basically is at risk of heart failure, which includes patients who didn't have previous history of any heart failure or present signs as well, and who have they don't have any structural or functional heart disease or abnormal markers, but patient may have hypertension, obesity, may have previous cardiovascular disease, obesity, exposure to cardiotoxic agent, genetic variants for cardiomyopathy, and familial history of cardiomyopathy as well. In stage B, there is pre-heart failure basically, wherein patient without current or previous symptoms or signs of heart failure, but has evidence of one among this. So can have structural heart disease, evidence of increased filling pressures, risk factors and increased natriuretic peptide levels, or persistent elevated cardiac troponin in the absence of competing diagnosis. Stage C is basically symptomatic heart failure, wherein patient has currently or has previous symptoms or signs of heart failure. Stage D is basically advanced heart failure, which we'll be discussing in detail further. It has marked heart failure symptoms that interfere with daily life and with recurrent hospitalization despite attempt to optimize the goal-directed medical therapy. These these stages basically therapeutic intervention in each stage aim to modify risk factor in stage A and treat risk and structural heart disease to prevent heart failure in stage B, and in stage C it is to reduce the symptoms. Both stage C and stage D, it's basically the therapy is to reduce symptoms, morbidity and mortality. Next, coming to NYHA classification. Basically, NYHA classification is used to categorize symptoms and functional capacity of patient with symptomatic heart failure, that is stage C and stage D heart failure patients. Clinician basically specify NYHA classification at baseline after the initial diagnosis and after the treatment through the continuum of care of the patient with heart failure. Although a patient with symptomatic heart failure, that is stage C, may become asymptomatic with treatment, that is he may go to NYHA class 1, but still he'll be categorized as stage C heart failure. So basically class 1 is no limitation of activity, no fatigue, breathlessness on ordinary physical activity. Class 2 is basically patient are comfortable at rest, but physical activity such as climbing stairs may result in symptoms. Class 3 is basically patient have marked limitation on physical activity but comfortable at rest. Class 4 where patient has symptoms at rest as well. Uh, the stage C heart failure patients can further be classified into four categories, that is new onset de novo heart failure, second is resolution of symptoms, persistent heart failure or worsening heart failure. New onset is basically newly diagnosed heart failure with no previous history of heart failure. In resolution of symptoms, wherein resolution there is resolution of signs and symptoms of heart failure. Stage C with previous symptoms of heart failure with persistent LV dysfunction is there. And persistent heart failure is with ongoing symptoms and signs and or limited functional capacity. Worsening heart failure is worsening symptoms, signs and functional capacity. Next, coming to heart failure classification based on ejection fraction. They are basically divided into four categories, that is with reduced ejection fraction, improved ejection fraction, mildly reduced ejection fraction and with preserved ejection fraction. So what is reduced? Basically with less than 40% is reduced ejection fraction. Improved ejection fraction is previously they would have had less than 40%, but on follow-up they have an ejection fraction of more than 40%. What is mildly reduced? Mildly reduces between 41 to 49%. And what is preserved ejection fraction? It's basically ejection fraction more than 50% with evidence of spontaneous or provocable increased LV filling pressures. Example, elevated natriuretic peptides, non-invasive and invasive hemodynamic measurements. Next, coming to clinical manifestation, the typical symptoms include breathlessness, orthopnea, PND, reduced exercise tolerance, fatigue, and ankle swelling. The less common symptoms are basically cough, dizziness, syncope, confusion, bloated feeling, and wheezing. Coming to signs, the most specific signs which we see is elevated GVP, hepatojugular reflex. We have third heart sound, laterally displaced apical beat. Less specific symptoms are wherein patient may have weight gain, which is 2 kg per week, weight loss, cardiac murmur, peripheral edema, may have tachycardia, irregular pulse, tachypnea, hepatomegaly, ascites, pleural effusion, oliguria, cold extremities with narrow pulse pressure. Next, coming to Killip classification. Basically, we have four classes, wherein class 1 is no signs of any acute congestion. Class 2 is rales or crackles in the lung with a S3 beat and elevated JVP. Class 3 is frank pulmonary edema, and class 4 is cardiogenic shock or hypotension. Next, coming to differential diagnosis, cardiac preferably can be due to which may mimic maybe angina, arrhythmias, atrial fibrillation, MI, pericardial effusion. The pulmonary causes could be aspiration pneumonitis, asthma, COPD, pneumothorax, foreign body, pulmonary embolism, pulmonary hypertension. Other causes can be anaphylaxis, anemia, mediastinitis, metabolic acidosis, panic attacks, renal failure, and toxins. Next, coming to the initial labs which are required, uh, that is complete blood count, urine analysis, serum electrolytes, BUN, creat, glucose, fasting lipid profile, LFT, iron studies, TSH levels, and electrocardiography. These initial labs basically provide important information regarding patient's comorbidity and even the suitability for the treatment and adverse effect what can happen secondary to the treatment, potential causes or confounders of heart failure, and it may also give regarding the idea regarding the severity and prognosis of the heart failure. Next, coming to the test which we do commonly from emergency initial test, bedside test, that is ECG. It basically identifies cardiac disease and the potential precipitating factors which has led to present heart failure. Chest X-ray, which gives an idea of pulmonary venous congestion, pleural effusion, interstitial or alveolar edema, and cardiomegaly. Echo gives an idea of the structural and the functional cardiac abnormalities, and lung ultrasound basically gives us an idea of the interstitial edema and pleural effusion and the severity of it. Next, coming to the X-ray. Based on X-ray, basically, uh, heart failure is divided into three stages. That is stage 1, stage 2, and 3. Wherein stage 1 basically shows signs like redistribution, cardiomegaly, and broad vascular pedicle. So, what is basically redistribution? This is the X-ray right side of a normal. It is just a normal chest film with the patient standing erect. The pulmonary vessels supplying the upper lung fields are smaller and fewer in number. You can notice the upper vessels actually which are smaller and fewer in numbers than those supplying the lung bases. The pulmonary vascular bed has a significant reserve capacity and recruitment. Uh, may open previously non-perfused vessels and causes distension of already perfused vessels. This results in redistribution which can be seen on this X-ray, uh, wherein you can see the even the vessels in the upper lobes which are more prominent. So this results in basically redistribution of the pulmonary blood flow. In stage 2, what we can see is curly B lines, peribronchial cuffing, hazy counter of the vessels, and the thickened interlobar fissure. Basically, stage 2 is characterized by fluid leakage into the interlobular and peribronchial interstitium as a result of increased pressures in the capillary. When fluid leaks into the peripheral interlobular septa, it is seen as curly B or septal lines. As seen in this image, these parallel lines which we can see in the peripheries, these are the curly B lines. Next, stage C is basically characterized by alveolar edema, wherein we can see consolidation, air bronchogram, cotton wool appearance, and pleural effusion. This stage is characterized by continued fluid leakage into the interstitium, which cannot be compensated by lymphatic drainage. This eventually leads to fluid leakage in the alveoli, leading to alveolar edema, and to leakage into the pleural space, leading to pleural effusion.